the next episode of our case presentations. I'm Dr. Piyush Bansal, Chairman of the Scientific Committee of Maharashtra, and I take extreme honor in welcoming our two young presenters, Dr. Vaishnavi Madrevar from Dr. Vittal Rao Vikhe Patil Foundation's Medical College and Hospital in Nagar, and her professor and head of department, and also her mentor, Professor Arundhati Pandey. Our second young presenter, Dr. Sanskriti Nahar, who's a junior resident at AIIMS in Nagpur, who has been mentored, and we have with us also Professor and Head of AIIMS Nagpur Ophthalmology, Professor Pooja Hingurani Bang, and Assistant Professor Dr. Vandana Iyer. We have two extremely well-known and I would say genius of the branch of uveitis in our country. One is, of course, my dear senior alumni, Dr. Mayur Morekar, who practices at Bombay Hospital, Mumbai, and my dear friend, Dr. Parthapratim Datta Majumdar, who's a senior consultant at Sankar Netralaya. Now, both of them are extremely well published. They are regular examiners at in various colleges of the country. I think Dr. Partha was in Pune in AFMC last week to conduct an exam over there. And of course, they are office members of Uveitis Society of India as well. So with this background, I hand it over to our moderator for the session, Dr. Archana Vare, who's professor and head at GMC in Aurangabad, and also member of the scientific committee. So, madam, can you just quickly begin?
So, good evening, everybody. So, we have two presentations today. So the time for presentation is around 8 to 10 minutes, and they will be asked questions by the esteemed examiners for 20 minutes. So Dr. Sanskriti will be presenting first. So she'll be presenting from 8 to 8:30, and from 8:30 to 9, Dr. Vaishnavi will be presenting. So I request Dr. Sanskriti to unmute and share her screen and start presenting.
Good evening, ma'am, and good evening, sir.
Good evening, Dr. Sanskriti. You can start.
रुक जाना क्यों रुक गया हो गया ना खत्म करना ये बंद करना होता है
Should I start?
If you can make it because this is a presenter view, so if you can just go to slideshow. Yeah, please start.
I'm going to present a case of bilateral uveitis deeper than it appears. A 30-year-old female presented with chief complaints of redness, pain, and diminution of vision since 6 days. The redness was acute, non-progressive, associated with photophobia. The pain was dull, intermittent, localized, with no aggravating and relieving factors. The diminution of vision was sudden and bilateral, right eye more than left eye. It was associated with headache, tingling, and numbness of both upper and lower limbs, and along with it, ringing sensation. It was not associated with colored halos, diplopia, glare, micropsia, metamorphopsia, flashes, and floaters. There was no history of any ocular or head trauma or any prior penetrating trauma or any prior ocular surgery or cough, fever, weight loss, or morning stiffness, joint pain, or any kind of oral or genital ulcer. No history of skin rash, alopecia, vitiligo, poliosis, diarrhea, or any blood in stool. The past history, she's a known case of diabetes and hypertension since 1 year and was controlled with oral medication. There is no history of asthma, thyroid, and TB. Family history, there is no history of similar complaints in the family members. And drug history, she's on oral hypoglycemic agents and on antihypertensives. Personal history, she consumes a mixed diet There is no history of any addiction. She has a normal sleep pattern with normal bowel bladder habits, and there is regular menstrual history with no history of any menstrual irregularities. There is no history of any allergy, and she is well immunized till date. Now, the general examination, she was conscious, cooperative, well oriented to time, place, and person, and was of moderate build and moderately nourished. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. The thyroid gland was not enlarged. Her vitals were stable. The pulse rate was 74 beats per minute, regular in rhythm. Her blood pressure was 138 by 80 millimeter of mercury. Her respiratory rate was 16 breaths per minute. Her SpO2 was 90% and temperature was afebrile, recorded to 98.6 degrees Fahrenheit. On systemic examination on cardiovascular system, the S1, S2 sounds were heard with no murmurs. On respiratory examination, there was bilateral air equal entry with no added sounds. The CNS examination, her higher mental functions were normal with no focal neurological deficits. In dermatological examination, there was no active any skin lesions noted, no depigmentations or vitiligo or alopecia. There was no organomegaly felt on per abdominal examination. Now, starting with the ocular examination, the visual acuity of right eye was counting finger close to face, PL present, and projection of rays inaccurate. In left eye, it was 6 by 60. With pinhole, there was no improvement in both the eyes. Her best corrected vision, so with plano, it was counting finger close to face only, and in left eye, it was plano 6 by 60 only. Near vision, it was less than N36, and in left eye, it was N8. The extraocular movements was free, full, painless in all cases. The intraocular pressure recorded with the help of non-contact tonometer was 80 millimeter of mercury in right eye, and left eye it was 60 millimeter of mercury. The central corneal thickness in right eye was 600 micrometer, and left eye it was 610 micrometer. Her corrected IOP was 40 millimeter of mercury in right eye, and in left eye it was 11 millimeter of mercury. The color, we also did her color vision by Ishara chart. It was 9 by 25 in right eye and 12 by 25 in left eye. On anterior segment examination slit lamp, we observed that in both the eyes, there was presence of circumcorneal congestion along with conjunctival congestion. The cornea was clear with normal size and shape with clear transparency and normal sheen. The AC was well formed with no cells, no flare, and the pupil in right eye was one in number, central in location, but was non-reactive to light. In left eye, it was RAPD, grade 3. The lens was in both the eyes, it was biconvex and clear in transparency. We can appreciate here the conjunctival congestions also. Now on fundus examination in right eye, there was presence of disc edema along with the obscuration of cup with segmental obscurations of blood vessels. And there was presence of elevation of whitish, grayish white membrane all over 360 degree of the retina with the collection of fluid, most probably suggest of RD, most probably serous fluid, and there was also presence of certain choroidal inflammation regions in the macula. Now, the fundus of the left eye, there was also there was presence of disc edema with obscuration of cup and segmental obscuration of blood vessels, and there was presence of grayish white elevation all over the 360 degree of retina, with the presence of certain hyper reflected yellow lesions at the level of RP layer and the choroid. Now, the provisional diagnosis, both eyes, there was presence of posterior uveitis along with exudative retinal detachment with optic neuritis in a 30-year-old female, a known case of controlled diabetes and hypertension. Now, our plan of management, firstly, we will begin with the ocular investigation. Should I move?
Yeah.
So the OCT, HVF, and B scan, and then systemic investigations were done along with medicine reference, who even advised certain more investigations. And her ENT reference was also done for tinnitus, where pure tone audiometry was done, and there she was diagnosed with sensory neural hearing loss.
Okay.
In
So
OCT, in both the eye, we could appreciate RNFL thickening, along with in left eye, there was superior RNFL loss. And there was in OCT of macula, we could appreciate elevation of hyperreflective elevation of membrane with collection of fluid, mostly subretinal fluid with multiple cystic spaces. The B scan was also done in right eye. There was presence of this hyper intensity membranes attached at retina, and there was also presence of mild choroidal thickening. As compared to the left eye, the amount of choroidal thickening was much more in left eye, and here also we can appreciate the white elevated membranes attached at the optic nerve head. Now we begin the treatment according to the JAB protocol. The IV methyl prednisolone was given 1 gram IV stat for 5 days, and which was then tapered with she was on then tapered by starting with oral prednisolone, which was started according to 1 milligram per kg per day. And while the course, when we tapered it, she again relapsed with the presence of keretic precipitates, for which medicine reference we can appreciate the presence of KPs in both the eyes. For this, an addition of immunosuppressive agent was done. So injection cyclophosphamide was given by IV pulse therapy, and along with Mesna, and like it was its dosage was 500 to 1000 milligram per meter square every for 3 to 4 weeks. Post treatment, the congestion, the circumcorneal congestion as well as the conjunctival congestion was resolved, and there was resolution of the exudative RD, and even the disc edema resolution was appreciated in OCT, and there was almost resolving subretinal fluid. But since for the complete resolution of RD, the Ozurdex implant was inserted in both the eyes, and post that, her vision in right eye came to be 6/24, and in left eye it came to 6/18. Thank you.
thank you, Dr. Sanskriti, for this wonderful presentation. And now I request Patu Pratim sir to ask questions to Dr. Sanskriti. Please stop sharing your screen.
Yes,
Sanskriti.
ma'am. Yes, ma'am.
So I think you managed, you presented it very well, Sanskriti. So the presenting symptom of your patient was something you started with. What was that symptom?
So pain, redness, and diminution of vision.
No, some systemic complaint you told, no? Numbness of the
Numbness and tingling sensation, both the upper and the lower limbs, and
numbness
along
of limb.
with
Numbness of limb, you said, I guess.
yes.
Yeah. So see, your viva, if you present this case in a viva, no, your presentation can start, the question may come in two way. One thing is that first question will be, what is your provisional diagnosis?
Since there was presence of, along with ocular features, there was even presence of certain systemic involvement, like it was more of a multi-system involvement disease. So we could think of certain autoimmune disorders, and like most probably it was pointing towards Vogt-Koyanagi Harada disease. due to involvement of ocular as well as certain neurological like
Very
numbness and pain. And
Very nice. But how will you classify this uveitis? If I have to anatomically classify this uveitis, how will you classify this uveitis?
sir, since there was presence of
So
coral,
you can just give me an answer. No need to give explanation. You just
posterior uveitis, but later on, since KPs were present, so even anterior uveitis was there.
So what you are doing, you are dividing the uveitic entity into multiple segments. Like why you are calling it anterior or posterior, or why you are using the term optic neuritis in this patient. It's a case of panuveitis where you can see the involvement of the so many structures. And optic disc involvement comes as a spectrum in the VKH disease. So no need to mention it typically. You can just tell it's a case of panuveitis. Most probably my first differential provisional diagnosis will be VKH. Now, the numbness of the limb is little atypical for a case of VKH. So I will suggest you should all revisit this history. Sometimes no, our patients, they will give some vague complaint which we cannot actually explain. Now, if you see in VKH, there will be a meningismus. There will be irritation of the meningeal irritation because of that antigen will be directed towards it. So it's very unlikely that that will cause numbness of the limbs because that goes to the spinal cord and that pathway is not for that. So if you start presenting this case, one of the criteria, a question may go towards that. So can you tell me a uveitic entity that can present as numbness of the limbs? Forget about the present clinical picture. It's presented with exudative retinal detachment, but I'm talking about a uveitic entity which will present as numbness of the limbs, multiple sclerosis, right? So how will you differentiate multiple sclerosis from this case? Because exudative RD is very uncommon in these cases of multiple sclerosis. It's not a very picture. I am also not sure why you have treated the patient in cyclophosphamide. But I understand that you have sent the referral to medicine department and they have only decided, I guess. I'm not sure about that part. Second part, if you are about that, then the next question will be why Mesna is given in addition to cyclophosphamide. Can you answer that?
Sir, because the cyclophosphamide has its side effect of hemorrhagic cystitis. That's why we give along with it Mesna to combat with it.
Very nice. And another important feature you missed while describing the ultrasound picture. Can you tell me what you miss? I'm sure you know that, but you missed it while describing it.
So tease a kissing correlation.
No. Something like some fluid you should see, no? Ask the patient to lie down. And again, shifting fluid.
Shifting fluid.
So whenever you were doing an ultrasound, you should mention that whether the shifting fluid was present or not. I think I'm done with the questioning. Mayur, over to you.
Yeah, thank you, Partha. Sanskriti, so what is your final diagnosis here?
Sir, Vogt Koyanagi Harada disease.
Yeah. So, can you tell me, can you classify this disease for me? How do you classify VKH disease?
Yes, sir.
Yeah,
Sir, mainly it's of three types: complete VKH, or incomplete VKH, or probable VKH. In complete VKH, we see both the ocular as well as cutaneous and neurological features. In incomplete, we see ocular. Then in addition, either the neurological or the cutaneous, and in probable only the ocular features are seen.
Okay. So your case here is what? Is it probable? Is it complete? Is it incomplete?
S- Sir, incomplete.
Why would you say that?
Ocular and like auditory manifestations were there, but cutaneous manifestation was not.
Okay, ocular and auditory manifestations. Okay, good. So what was the auditory manifestation which was there?
Like tinnitus, ringing sensation.
Something else was there? You sent a ENT reference for tinnitus.
Yes, sir. Sensory neural hearing loss then was diagnosed.
Oh, so BKH disease, what is the treatment? I mean, you have told the treatment here, but can you just elaborate the treatment for me once?
Yes, sir. Firstly, we begin with the methyl prednisolone,
Yeah,
and along with it, we add immunosuppressive agents, and
okay.
in certain cases, even biologicals like infliximab are also used.
What are the immunosuppressive agents that are generally used that you know of?
Sir, cyclophosphamide,
Okay,
azathioprine, and
okay,
uh, yeah, even sir, cyclosporin
okay.
and
Something that starts with,
methotrexate.
yes, methotrexate, and one more
Methotrexate.
that starts with M again.
Is what's that? Pardon?
There's one more that
Sir,
starts with M.
sir, mycophenolate
Mycof.
mofetil.
Yeah.
Mofetil.
Okay. Very good. Can you name any of the biologicals? You named one of them, infliximab. Do you know of any?
Yes, sir. Infliximab and adalimumab and
Oh,
rituximab.
okay, okay, fine. So you have infliximab, you have adalimumab. Tell me, in this case, how long would the treatment continue? Now, this patient has come to you, you have given her treatment, she is now better, she has regained back some vision. Now, she is asking you about the uh, duration of treatment. So, in BKH, how much would you expect the duration of treatment to be?
Sir, what I have observed in this case was that even after her vision improving to 6 by 24 and 6 by 18, later on when we were tapering the drug, it was again relapsing. So even like for 3 to 6 months also after tapering, the disease may relapse.
Okay. Now, if you are having multiple relapses in BKH, then what would be the side effects? I mean, what does a chronic VKH look like?
Sir, due to intake of steroids, she was having like cushingoid features and all. Cushing
That is
disease.
what those are the side effects of
Hmm.
the treatment. I am asking you, what does chronic VKH, what does the fundus in a chronic VKH look like? The fundus
Uh,
picture would look like what?
uh, it's a like there's a presence of a sunset glow fundus, we
Sunset.
call it.
Yeah.
And
So sunset glow fundus will point towards what? If
so
there is
it's
a
chronic VKH, like classic
yeah,
sign.
chronic VKH. So would sunset glow fundus, if you see a sunset glow fundus in a patient with VKH, would it mean that the patient is adequately treated or inadequately?
Uh, um, s-
I'm sorry, I couldn't hear you.
I think she is finding it a little difficult. Let me
Yeah.
ask you a very simple question. Can I ask Mayur?
Yeah, sure.
Yeah. Can you tell me differential diagnosis of a case with exudative RD? I think that's more.
yes, sir. Firstly,
Yeah.
so firstly, we can think it may be due to hypertension, and mostly in cases of like pregnancy-induced hypertension, or in cases of central serous retinopathy,
Exactly.
or like trauma related to sympathetic ophthalmia, and then VKH.
So can you tell me what one important investigation actually you missed in this case, which ideally you should do?
Sir, HPF.
HPF, imaging, just imaging you ideally you should do. I'm not telling that, but you can actually find out. One of the differential diagnoses you have mentioned just now, sometimes if you are sending, for example, you have started your clinic and you have seen a case of exudative RD and patient is complaining of some kind of headache, and thinking about this case, you directly send the patient for intravenous methylprednisolone. And the patient is coming back with marked increase in the heights of the bullous retinal detachment. Then what you are dealing with deterioration of the exudative RD with pulse corticosteroid. What can be the differential diagnosis? And what important message we should take from this discussion? It's a fundus fluorescent angiography. Because you mentioned that most common will be central serous retinopathy. So any case, in our patient profile, most of the patient will come to your clinic and will give a history of headache. And combination of these two can actually lead to sometimes the misdiagnosis of a case of VKH. So you ideally, any case of exudative RD, you should do a fundus fluorescent angiography. Now, can you tell me how will you differentiate a case of VKH from CSR based on fundus fluorescent angiography? What will be the changes?
Like, so in CSR, it is a characteristic smoke, ink blot or smokestack pattern.
Very good. So what will be the changes you will observe? How the dye will behave? You are right. It will be smokestack or it will be ink blot. But how the dye will behave when it will reach the retina? And how the dye will behave when it will reach a case of Vogt-Koyanagi-Harada disease?
Sir, in cases of Vogt-Koyanagi, there will be a stack leak, but in cases of sir, in case of Vogt-Koyanagi, there will be multiple pinpoints leak.
Yes, but multiple pinpoint leak can be seen in multifocal CSR also. So the dye will start with a pinpoint leak. Then in middle and late phases, the characteristic will change. In CSR, that pinpoint leak will start increasing in size and intensity. Correct. But in VKH, it will lead to a placoid film. But because in VKH, there are compartmentalization of this fluid. You have shown correctly, that in OCT, you can see the fibrous septa. So that will divide the fluid into multiple compartments. And so the dye will go and will start leaking and you will fill those pockets of fluids. So it will appear as a placoid pooling. Remember this term for the exam purpose, that it will lead to a placoid pooling. Whereas in CSR, the dye will increase in size and intensity. Clear?
Yes.
Yes.
So I think we are coming close to 8:30. Sanskriti, you're a first year resident, second year, third year?
Sir, I'm second year resident.
She
Yeah,
just
so
finished her first year and now she has entered second year.
So I must say that you presented very well. And when I was a second year resident, I would get confused between VKH and VKC. And you are here presenting a case of VKH in front of all of us. So that is really commendable. Very well done. And I think if madam, you have any questions, you can just put them.
No, I mean, it's time to move on to the second case, but still we have like 2 minutes. For 2 minutes, we can ask any more questions if you have.
Question, but I want to echo Mayur's thought. Yes, brilliant presentation. I am surprised that she could answer that question also, no? That how will you classify this VKH?
Yeah.
It's like really very nice. Thanks.
Yeah, and ma'am was just telling me that she's a first year student. I mean, she has just finished first year and she has gone to second year, and Ma'am was little worried that how she'll answer the questions, but she has proved that she's been ably mentored by Pooja ma'am and her mentor. So, so can we move on to our next case, sir?
And I'd just like to add that Vandana could not join because she's not very well. I was messaging her, but she is the one who's behind this case. So,
I think she's there.
yeah.
I came.
Okay, she's joined. Okay, great. Vandana on
So,
time. Yeah. So,
so I've been listening. She's doing really well. Yeah.
Yeah. She did very well.
Yes, ma'am.
So with that, we will move on to our next case, and the next case will be presented by Dr. Vaishnavi, and her mentor is Dr. Arundhati. So I request Dr. Vaishnavi to share her screen and start presenting.
Good evening, everyone. Ma'am, am I audible?
Yeah, you are audible and your slide is also visible.
Uh, a 36-year-old female resident of Ahilanagar came to OPD with chief complaint of redness, pain, watering, blurring of vision, and photophobia since 4 days. She was all right 4 days ago when she started complaining of redness, which was associated with watering, photophobia, blurring of vision, and pain, which was severe and radiating to the forehead. There was no history of sticky discharge, colored halos, nausea, vomiting, fever or rash, night sweats, cough, oral ulcer, genital ulcers, back pain, back stiffness, joint pain, diarrhea or any altered bowel habits. There was no history of diabetes, hypertension, COPD, tuberculosis or bronchial asthma. And there was no history of ocular surgery or trauma. She had a similar episode 6 months ago, which resolved without medications, and there was no drug history, and the family history is not significant in this case. Her personal history is diet is mixed, the sleep is normal, and bowel bladder are regular. She is conscious, oriented to time, place person. Her pulse was 70 beats per minute, BP was 130 by 80. And respiratory rate was 14 per minute. Her temperature was afebrile and there were no signs of pallor, icterus, cyanosis, lymphadenopathy or pedal Her systemic examination were also normal. There was no abnormality detected in them. The next is ocular examination. Her head posture was normal. Ocular movements were free and full. Eyelash, eyebrow and eyelid were normal. The right eye of my patient is normal, so I'll be presenting the findings of the left eye. Her vision was 618 and vision with pinhole was also 618. There was presence of circumciliary congestion as well as diffuse conjunctival congestion. Cornea showed fine KPs. Anterior chamber had AC cells +4, aqueous flare +1, fibrinous exudate were present. Hypopion was 1 mm into 1 mm, which was immobile, and AC had normal depth. The iris was muddy, and pupil was miotic, sluggishly reacting to direct and indirect light, and posterior synecdoche were present from 10 o'clock to 1 o'clock and at 6 o'clock and 7 o'clock. On anterior capsule, iris pigment was present. IOP was taken with non-contact tonometer and it was 18 mm of Hg in both eyes. And their sac was patent as it showed no regurgitation on pressure. The fundus of the left eye was not visible. Red glow was visible and it was hazy. B scan was done for this patient and it showed no abnormality in the B scan. On presentation, we can see there is diffuse congestion as well as circumciliary congestion. It is a meiotic pupil with the presence of hypopyon and AC cells as well as flare. This picture shows fine KPs which were present. So my provisional diagnosis is left eye acute non-granulomatous anterior uveitis. These were the investigations done for the patient. It showed that she had elevated ESR and CRP levels. All other findings were negative, as well as urine examination showed no pus cells, and stool examination was also normal. Montauk's test was done, which was normal, and radiological investigation like chest X-ray and sacroiliac joint X-ray was done, which showed no signs of sarcoidosis or TB. I started the patient on prednisolone acetate 1% eye drop for 6 times and homatropin eye drop 2 times a day. After 7 days, she visited back with resolution of hypopyon. AC reaction was decreased to +1, and also Synike were broken, but there was still presence of Synike at 10 and 11 o'clock as well as 7 o'clock.
Thank you. Will you please stop sharing your screen, Dr. Vaishnavi?
Yes.
Yeah. So, Mayur sir, you can start asking questions.
Yeah, Vaishnavi, a very good case, and I must say, very good photographs. So, can you tell me, so your case, your final diagnosis was, what was your final diagnosis?
Sir, left eye acute non-granulomatous anterior uveitis.
So when you have a patient with a acute non-granulomatous anterior uveitis, what history would you ask? One history that you would want to ask in
Sir,
relation
firstly, I
to,
would like to ask about the onset. What
yeah,
symptoms were present first? After
yeah,
that, I would like to ask about any systemic correlations with it, like if she had any joint pain or her bowel bladder habits, plus if there are any lesions on her skin.
okay. So just wait here. So when you say joint pains, what are you going to ask for specifically?
So specifically, I would like to ask her about her back pain or back
Okay. What?
stiffness
Yeah. So you're asking for
or
back stiffness at what
for
time of the day?
ankylosing spondylitis, sir.
At what time
Seronegative,
of the day?
sir, in the morning, if it is more severe in the morning and resolving during the day.
Okay. When you say bowel bladder movements, then what are you looking for?
Sir, I am looking for a history of any ulcerative colitis or Crohn's disease.
Okay. And when you say skin related, what are you looking at?
Sir, if ulcers are present, I'm looking for Behçet's disease. Also, it
Okay.
can be seen in psoriatic arthritis.
Okay.
And syphilis also shows the presence of lesion.
So when you put these three things together, four things together, non-granulomatous anterior uveitis, early morning lower back stiffness, some bowel bladder issues, and say psoriatic arthritis, then which syndromes are you looking at? What
Sir,
syndrome?
HLA-B27 associated syndromes.
Okay, very good. So HLA-B27 associated syndromes, what do they come? What is the presentation called? You just now said it also. It is called ankylosing
Sir, seronegative spondyloarthropathy.
seronegative spondyloarthropathy. Okay. Now, see, whenever you see that there is a hypopyon,
Yes.
what would be the first thought in your mind? I mean, whenever you say hypopion, would you think of this disease or would you think of something else?
Sir, I would also think about an infective cause.
Yeah. So how would you differentiate? Uh, how would you be sure that this is not an infective cause?
Sir, infective cause like endophthalmitis would show more decreased vision. The
Hmm.
symptoms will be more marked,
Yeah.
and she will have the involvement of posterior segment as well. There
Okay.
might be history of trauma or surgeries,
Okay.
and there
Fine.
can be an infective foci
Yeah.
somewhere.
Okay. So, in a case of HLA-B27 uveitis, how would you treat?
Uh, Sir, I would like to proceed with thorough slit lamp examination.
Yeah.
Then I'll ask elaborate history, and I'll try to pinpoint it towards a disease.
Okay.
If not possible, I will still start her on prednisolone acetate 1% eye drops according to the severity, 8 times or 6 times a day, and homatropin eye drop 2% to break the syncytial,
Okay.
and it will
So
also relieve her pain.
last question from my end. See, in your case here, the intraocular pressures were normal in both
Yes,
eyes.
sir.
In severe HLA-B27 anterior uveitis, would you expect the pressure in an acute stage to be normal, low, or high?
Sir, in acute cases, I would expect it to be high
Okay. So that's one.
because
So that's one thing that can happen. But generally, when we will see the pressure to be low. That's because, the ciliary body, when it is extremely inflamed, then there will be something like a
it goes
shutdown.
into ciliary
Yeah.
shutdown.
Yeah. Partho, you can comment.
Yeah, I think very nice presentation once again. I'm really impressed the way you're answering the questions. No, it really reflects very nicely, and credit I think goes to your mentor also. I think they'll be feeling very proud. Okay, can you tell me just exam related quick questions? Can you tell me what is the role of cycloplegic in such cases?
The cycloplegics, firstly, it is given to break the posterior syncytial. Also, they relieve the ciliary spasm and relieve the pain of the patient. They also decrease the hyperemia,
Very
and they they don't let posterior syncytial form again, prevent the formation.
okay. How will you differentiate between homatropine and atropine? What is the basic difference between these two?
Duration of action.
Very good. So which one is long acting?
Atropine is long acting, and homatropine works up till 3 days. Atropine might work up to 7 to 10 days.
Very good. So other than HLA-B27 uveitis, can you name another uveitis which will present with hypopion?
Sir, Behçet's disease.
Very good. So can you tell me some characteristic of Behçet's hypopion and how to differentiate it from a case of hypopion associated with HLA-B27?
Sir, Behçet's hypopion will have less of fibrin content, so it will be mobile and it will resolve faster than this hypopion.
Brilliant. Very nice. I'm very happy. Okay. Tell me few more differentiating points.
Sir, in Behçet's disease, it is
Okay.
usually bilateral.
Let's stick to the hypopion only. So what are the other characteristics?
Um, so the color of the hypopion in HLA-B27 cases will be dirty white, whereas in Behçet's it might be a more pigmented.
And sometimes it can be streak hypopion, and sometimes we call it microhypopion because it's a very minimal. So sometimes you can actually see them only when you do the gonioscopy. Okay, so now coming to that, how will you differentiate a case of HLA-B27 and Behçet disease only by ocular involvement? You tell me the ocular features. No need to mention about the systemic feature.
Sir, in Behçet's, the involvement can be bilateral. Also, the symptoms might be moderate, whereas in HLA it might be
Posterior segment
severe.
can be.
Yes, sir.
What about the posterior segment involvement?
Posterior segment involvement can be seen in Behçet's disease
Yeah, in the form of?
in the form of, vasculitis.
Very good. Very good. So you will see the retinal vasculitis in Behçet's. And HLA-B27 usually they don't manifest. Okay. Now coming back to the anterior uveitis, can you tell me 3 common causes of anterior uveitis? One is HLA-B27. Can you name other 2 causes?
Sir, Fuchs
Very good.
and
Next.
viral.
Very. Now you tell me, how will you differentiate a case of Fuchs uveitis, viral anterior uveitis, and HLA-B27?
Sir, in Fuchs anterior uveitis, the congestion is very low. It is mostly not present. The AC reaction is also very less. Also, the keratic precipitates will be fine. In viral, there is a increase in ocular pressure,
No,
coin-shaped
about
keratic precipitates.
in Fuchs.
Sorry, sir.
Fuchs, what kind of keratic precipitates you'd expect?
Stellate shaped, sir. Sorry, stellate shaped keratic precipitates can be seen in Fuchs.
Yes.
And fine can be seen in the viral. Intraocular pressure is markedly raised in viral uveitis. And coin-shaped or linear KPs can be seen in viral uveitis.
Now, can you tell me about the laterality? How will you differentiate?
Sir, usually in viral, the same eye is recurrently involved, but in Fuchs, alternate eye, and in HLA-B27, the alternate eye can be involved.
And Fuchs?
Fuchs is usually unilateral, the same eye.
Okay. So, any other features of Fuchs uveitis? One is stellate KPs, one is unilateral. Other than, you will see and you will...
Sir, the iris pattern will be lost. Velvety iris will be seen.
Very nice.
And in cases the people who have light iris will show heterochromia.
Yeah, one more thing related to iris, some complication related to iris.
Sir, patchy atrophy of iris will be seen in your viral. But in
Yes.
Fuchs,
Just now we
transciliar.
discussed about the drug, whether you will need that drug in Fuchs.
Sorry,
Homatropine,
sir.
homatropine or atropine is required in Fuchs.
No, sir. It won't.
So absence
won't add.
absence of synechia is one of the features.
Yes, yes.
Usually you don't see.
Yes.
Correct. And how is the cataract?
Sir, posterior subcapsular cataract.
Most type of cataract. Correct. And about the posterior segment involvement, is there any kind of posterior segment involvement you see in Fuchs uveitis?
I'm not able to recall, sir.
Excellent. I think she has answered all the questions.
Yeah.
Mayur,
I
sir.
think very well answered.
Yeah, we still have 10 minutes, so you can ask the questions.
I guess I believe we are more or less done. Partho, you want to ask something?
Yeah, that's it. Very difficult. I can understand their conditions. They are feeling why. Okay. Since the discussion is on UVITs and all, so can you tell me how will you draw a diagram of the this thing UVIT case? Slit lamp diagram. Hypopion. What is the importance of documenting a case of hypopion in exam? For example, the previous patient, or whether if there is no hypopion, whether you need to mention it. I'm asking straightforward question.
Yes, sir, we have to mention hypopion,
Mention what?
and it is drawn in a color coding with yellow or orange color, and the dimensions are written.
What is the
Also,
dimension?
the mobility. Sir, in my case, it is 1 mm into 1 mm. The
So even if you remember one thing, that Sun classification says that if you are documenting a case of anterior uveitis, even the hypopion is absent, you need to mention that there is no hypopion. So that is mandatory for documenting a case of anterior uveitis. Second most important thing is that you're documenting the synechia. So synechia, ideally you are supposed to mention the clock hours, that which clock hours the synechia is there. Yeah, I think her internet connection is,
Oh, yeah.
yeah.
Sanskriti, are you there?
No, she is Vaishnavi.
Yes, ma'am. Yes.
Yeah. Sanskriti. The other student till Vaishnavi logs in again. Yeah.
I think Sanskriti has answered all this thing, VKH and all. Sanskriti, how do you differentiate sympathetic ophthalmia, Vogt-Koenige Harada disease, and posterior scleritis?
Sir, in cases of posterior scleritis, by B scan, we can see the T sign. And in cases of sympathetic ophthalmia, firstly, the history of penetrating trauma will be there. And in cases of VKH, there will be no trauma history. And usually, VKH is multi-system involvement. Not
Correct.
only in sympathetic ophthalmia, there will be a restriction to eye only ocular, but
Correct.
in VKH we will have multi-system.
Yeah. Can you tell me one more thing, that you are telling that penetrating trauma? So is only the penetrating trauma is the only cause for sympathetic ophthalmia, or it can happen without penetrating trauma, some kind of other?
Yes. Yeah, yes, sir. There can be multiple cause, even after autoimmune any reaction, or even if one eye is injured, the other eye will sympathizes that thing. Or even in cases of due to autoimmune reaction, in case of these against uveal melanocytes and
Any trauma?
what's that?
Any planned trauma to the eye?
Any plant trauma. So it can be retained any intraocular foreign body.
These are all accidental trauma you are talking about. I'm asking any planned trauma. What do you mean by planned trauma?
So like intraocular surgeries and
Yeah, exactly.
cataract
So,
and
so a planned trauma also can cause. No, so what is the most common planned trauma related to sympathetic ophthalmia? What kind of surgery?
cataracts.
No, cataract is not needed. Multiple vitreoretinal surgery is one of the risk factor, but it can happen with any kind of surgery. So I'm talking about the most common cause. I think that's point back, but you have answered all the questions. You are
sorry, sir, I actually lost the connection.
Yeah, no issue. Dr. Archana, I think you are muted.
Oh, sorry. Sir, I think she's back. So, and we can ask more about the investigative part, sir, from exam point of view.
He has answered all. Okay, what all investigation you will do in case of anterior uveitis?
Sir, firstly, slant history, and then I'll go to basic hematological examination.
Laboratory investigation related to uveitis.
Then ESR. Sir, ESR CRP for systemic association if there is a systemic inflammation as well. I would like to do a serum ACE to rule out granulomatous and anti-nuclear antibodies.
HLA-B27.
Also, sir, skin test like Montux I'll do to rule out TB, and radiological examination like chest X-ray to rule out TB and sarcoidosis. Also, X-ray sacroiliac joint to rule out ankylosing spondylitis. If the case is, sorry, sir.
Viral uveitis.
Sir, in viral uveitis, we can go for PCR with aqueous tap.
You are in first year or second year?
Sir, I have just entered third year.
Oh, great, great. I think that's all from my side.
Mayur sir, would you like to
Yeah.
ask any questions?
No, not really. I think both of them have done pretty well. I mean, they have answered all questions,
Okay.
especially, the rapid fire questions that Partha was putting. Really good.
Yes.
Full
Yes.
marks to both of them.
Yeah,
Yeah.
so nice. So a quick feedback from Dr. Arundhati and Dr. Pooja ma'am. So I'll go to Dr. Arundhati first.
Yeah, it was so I would like to say thank you to MOS, thank you to Dr. Archana ma'am, thank you to Dr. Partho and Dr. Mayur for this very good discussion and very good initiation. I'm really grateful to give this opportunity and really good, nice discussion actually. I really enjoyed. Thank you.
Thank you, Dr. Arundhati. Pooja ma'am. Ma'am, you're mute, ma'am.
Yeah. So thank you so much. I'm so grateful that my students are getting this kind of exposure from the very best in the country. And if y'all came as examiners and the examiners taught at the same time as asking questions, it's the icing on the cake. So I think it's very good for my students to be exposed to this. And special thanks to Archana ma'am and MOS for getting such the best of the best over here. Thank you so much.
Thank you, Pooja. Partho sir and Mayur sir, your comments, please.
I think I'm really surprised the kind of the answers they gave. Means all difficult. It was like a near perfect show for me. Means almost all the questions they answered. So it's very surprising for me to see the postgraduates know so much about uveitis and the management. So it's really a great experience.
Thank you, sir. Thank you. Mayur sir.
Yeah, I think I'll echo what Partha has said. Presentations are very good. The photographs which they have put, the imaging pictures that they have put are also very good. It is very obvious that a lot of effort has been taken from them and also from their mentors for making the case and presenting. So I think that's very nice.
Okay, so to conclude, I would like to thank Partho Pratim sir and Mayur sir for their valuable time and for asking questions to the students. I'm also thankful to Dr. Pooja ma'am and her student for this wonderful presentation. And I'm thankful to Dr. Arundhati and Dr. Vaishnavi again for an amazing presentation. And both the students did so well and they answered all the questions and most of all, they could meet the expectations or they, higher achieved the expectations of the examiners. So with this, we will conclude today's session. So thank you everyone from the Maharashtra Ophthalmic Society. Thank you.
Great girls. Both the girls were brilliant and excellent. So thank you. Yeah.
Thank you.
Good job. Bye. Good night.
Bye.